We are here with Dr. Nick Kulkarni, who is doing a question and answers following his amazing webinar on managing predictable results with EthOss synthetic bone grafting. Thank you, Dr. Kulkarni. We'll go over some questions this evening, and if you could answer them for us, that would be wonderful. So question number 1, can you use EthOss in most of your grafting cases?
Yes. Now, EthOss is actually my go-to material. I don't actually stock anything other than EthOss. I don't really see any reason why I should use anything else.
Question number 2, do you have problems with reddish mucosa after graft placement?
Sometimes, in some cases, you do have that issue, but it's got nothing to do with the EthOss as such. I will have to look at it case by case and check what you mean by reddish mucosa. But most of the times, graft failure happens because of improper closure, and it's in the technique, or there's trauma to the wound, or sometimes there can be tissue overgrowth. I had a that case will probably be ready for the next webinar, where I'd done an immediate implant with EthOss in the jump space with a healing abutment, but the tissue completely grew over top of it and it closed up. And it didn't close up completely, it sort of closed up halfway through. So there was ingress of bacteria. And then the whole EthOss was completely lost, or it became fibrous, in which case then I had to open up. The implant had integrated, thankfully. So you have to sometimes go back in, curate that site, and then close it again. So these things can happen. It is all about bacterial contamination, and we work in a unique environment as compared to other surgeons, where once our wound or incision lines are bathed in bacteria. So we are going to encounter these problems on and off, and we can minimize them, but we can't completely avoid them. Does that answer the question? If that person who's asked the question, if you want to send me photos of your actual, what do you mean by the reddish mucosa? I suppose it's inflammatory and not infected, but we can look at it case by case, I think.
Question number 3, how hard is EthOss after setting? Is it as hard as dental plaster when set?
Almost. A little bit weaker than dental plaster when set. It's sort of the early warm stages of plaster when it's trying to set. That's the sort of consistency you get. So once EthOss is set hard, if you pierce it, it will break out. It'll break. It won't scrape off. It'll actually, it's brittle almost. So I would say that's the consistency that has given me the best results. Now, some people say, oh, it doesn't matter. You can use it whichever way, pack it in, and it still works. In my hands, if I respect the material, it works much better, is what I've seen.
Question number 4, for a lower molar immediate implant case, does the site need to have primary closure? If so, would you raise a flap?
So I've shown you 2 cases in my presentation of immediate molars. And I have to say, I've shown some immediate molar cases, but it's not something that I do regularly. These are some of the weird cases that I've done, and I picked them up for the webinar. But if you want to minimize your risks, it's probably nothing wrong in doing the extraction, waiting for it to heal, and then you've got soft tissue closure, and then do a predictable implant. So I don't always do lower molars. My presentation does have 2 immediate lower molars, and you might think that I'm actually doing them all the time, but that's not the case. Now let's look at the 2 immediate molars that we've done. Should we go back to the slide? I'll share my screen now. Okay, so this is the lower molar that a lot of people are asking about. Now, I haven't really raised a flap in this region. This is how I preserve so what you really want to do is prevent severing the junction where the periosteum meets the top bundle bone as much as possible. You can't completely avoid it. The fact that you've taken out the tooth, that means that bit of bundle bone is lost. But you don't really want to sever that junction as much to prevent any bone loss. As soon as you raise epithelium or as soon as you raise epithelium off the bone, you will have some amount of bone loss. So you want to preserve it as much as possible. Now here we have placed the implant in bone, and it's at the correct 3D position. It's sort of 3 mils below, it's nice and deep, 3 mils below the crest. And then there's a healing abutment, and this is part of EthOss is placed. I should have kept a photo of the suturing. Now, once I've packed EthOss in these extraction sockets, I've just taken normal sutures to evert the wound edges as close as possible. I've not gained primary closure in this. Whereas the other side, if we were to look at the other slide where we have gained primary closure, or attempted to gain primary closure, you can't really get a very good primary closure on immediate molars that easily, because so this is the second immediate molar that we've done on the upper. Let me see if we have a right. So here I had actually released the periosteum because I was grafting a lot more on the buccal of that implant on the outside as well. And so here there was a periosteal release incision, and then here I tried to attempt taking a complete primary closure. The disadvantage of taking or trying to achieve a primary closure by raising the periosteum is once your tissues heal, you'll have limited amount of keratinized tissue. So you really want some amount of secondary intention healing rather than the primary intention healing. So while the secondary intention is happening, you'll hopefully get some amount of keratinized tissue, and that tissue will be a bit stronger around the neck of your implant.
Question number 5. When do you do the periosteal release of the flap?
When you want to get primary closure.
And I think maybe when in the procedure would you do your
Oh, when in the procedure,
release?
I would do the primary close. Let's go back to the videos of EthOss. I'll show you again. Yes, so ideally before I mix the EthOss, I've cleaned out the tissues. I've separated the periosteum, and I've got the nurses to hold the gauze down there to maintain the site nice and dry. And then that's when I would go behind, mix the EthOss, bring it in and inject it, and then wait for it, and then put a gauze on top to then let the EthOss set. And this whole process should take about 3 to 4 minutes, 5 minutes at the most. You don't have much more working time with EthOss anyways. So, and then once it's set, you close it. On that note, you can take a periosteal release even after EthOss has set. So if you've forgotten, or for whatever reason you think your flap mobility was okay before, and after you've grafted, you feel the flap mobility is not enough, you can still do it. So it's not like the time is completely lost. All you need to do is make sure you don't disturb the set EthOss and break it while you working with your instruments in that region. So you just have to be a bit more careful. That's all.
Question number 6. Why don't you need a membrane when using EthOss? Do you have cases where you would use a membrane?
Now, so there's much confusion about this topic, and this is, I would say, Ash, this is the most frequently asked question.
It is.
So we have to think, when we're working with EthOss, we have to rethink the way we do grafting. With bovine materials, essentially what we are so trained, and so many years we've been using it, we are trained to have a bloody site, and we mix the graft in and soak it with blood. This is reverse of that. So it's a bit confronting in the way that you almost need a dry site for this. It's almost like you're doing a restoration, so to say, like a tooth supported restoration. So you need a dry site as much as possible. Now, when you mix EthOss with saline, there's two components to EthOss. There's beta-dicalcium phosphate and calcium sulfate. Is the calcium sulfate that takes up the saline and provides the setting reaction to the beta-tricalcium to the whole product. Now, calcium sulfate also acts in sort of reducing the proliferation of osteoclastic activity, and it also reduces the differentiation of the progenitor cells. So your calcium sulfate, once it's mixed, that actually forms your membrane. Now, if you put a membrane on top, you will have EthOss sitting in there doing nothing, rotting away below the membrane, because there is no cell turnover that started. You really want the cells to go and start differentiating into osteoblasts. And of course, there will be osteoclastic activity, but the said calcium sulfate will prevent and reduce the amount of osteoclastic activity. So that's the chemistry behind the whys of why, we don't use and recommend a membrane. In fact, it'll work against. There have been questions asked, oh, should we use a PRP plug on top? I don't think there's much, or anyone's done much studies of whether they should put the PRP plug on top on all sorts of things. This is working quite well with the techniques that I've shown you. And I feel if you stick to the recipe, you'll get more predictable results.
Question number 7. What is your consideration for not using a membrane in your EthOss cases? Are you comfortable that EthOss won't resorb early, resulting in soft tissue ingress?
This question was similar to the one we already answered. So coming back to it, so we actually want the soft tissue or the cells from the periosteum really to start working on that region. So you don't really want to block out the cells. So cellular activity is important once you place EthOss. And we were talking about the setting consistency. I think there is one video there. Was it this? Yeah. So that's how EthOss should sit. The elevator actually bounces off the material. So resorption of EthOss, I think it's coming back to the way xenografts work. The xenografts, because soft tissue ingress grows faster, and you don't really want soft tissue ingressing into a xenograft site, because then you'll have a fibrous mulch that will be created in the region. With EthOss, it's a bit different. You want the periosteal cells to go and start differentiating, because it works with cell signaling. So I'm very comfortable not using a membrane. In fact, a membrane is not recommended.
All right, question number 8. How do you prevent washout of EthOss when doing socket grafting when you cannot get primary closure?
So socket grafting, again, I don't routinely do socket graftings. I think the most predictable protocol is if you do an early implant placement. So you do the extraction, wait for 8 weeks, and there's no graft at that stage. You're basically just curating that site really, really well. You wait for soft tissue healing at 8 weeks, and then you go in and place your implant and then graft at the same time. That would be I would say, the most predictable way to go about an implant.
Question 9. In regards to the occlusal gingival space after implant and healing abutment placement, this is referring to case 10. What would you use for occlusal closure in a large buccal to lingual gingival space?
I mean, if the space is that wide and large, then maybe it's not a case. Maybe it's not a good case for an immediate implant. So you might want to wait for the soft tissue to heal and then do it. Or the other option is to then raise a flap and then try to gain primary closure to around the neck of the healing abutment, or if you've buried it, then or completely on top. But if the defect is so large that you can't really a few mils of defect opening, I think the blood clot will form over there and stabilize on top, and you'll have soft tissue growth quite rapidly on top. So you won't have a problem with washout. But if you have a big gaping hole and you've put EthOss in it, it is going to wash out. There is bacteria in the mouth. It will still heal. It still heals, but you won't have good bone conversion in that region.
Question number 10. In your hands, how predictable is EthOss?
Well, I would say it's very, very predictable. It is as predictable as, I would say it's probably more predictable than any other material that I've used. Also, it does have a bit of a learning curve. So the setting part of it, the mixing part of it, it does take a little bit of time. And also, when I started using EthOss first, I struggled with the fact that you have to have a clean, dry field. So it's almost against what you've been taught for so many years and what we've been following for so many years. So the learning curve is not very steep, but there is a learning curve with EthOss. So you
Excellent.
can't just place the material and expect it to start growing bone from nowhere.
Okay, question 11. Please comment on the amount of saline that you use to mix EthOss, and what do you do when it doesn't seem to set?
If it's not setting, that means it's been rehydrated twice. Usually once you use as little as possible and as much as necessary. Sorry for the play of words. But that's really, I mean, I think you should order, Ash, you can order from Ash some practice kits and the non-sterile ethos and have a little play with it. Make sure you mix it well and then express it. And once you express it and pat it, it should ideally set. Should we see the video of that? Now, with the 1 cc ethos, I found that wetting of the ethos all the way down is a little bit of an issue. So the saline doesn't go all the way through. So I stick an elevator inside just to make sure that it's all in there. And if you pull the syringe backwards, that's so 1:1 ratio is pretty good. What do you think, Ash?
1:1 is good, slightly under is better, as
Yeah.
long as you said you're using something to mix it then, because it doesn't always penetrate to the very, very base of the ethos in the
Correct.
syringe, and you do want it mixed consistently throughout the mix.
Let's say you have these two sites and you're ready to just do the one site of grafting. So I actually sometimes express it. I have a little metal well in my surgical kit, and so you can express it out a little bit in a little in a sterile dapping dish, metallic dapping dish, and you can mix it outside, dry it with a gauze and stick that first. Like you actually just spoon feed it to the site, and then you can use the rest again that way. Or you could have 2.5 cc's and mix them separately. Now,
I do recommend to split a 1 cc for multiple sites, or layering grafting, because you don't want to mix a whole load of ethos before a multiple
correct.
site placement,
Yeah.
because it will
Yeah.
sit on you.
So here, let's have a look at this video. So that's the mixing. That's the amount of water I'm putting. That's very little. Just a few drops in there. And then we are making sure I'm wetting it all the way through. And then you just squeeze out the excess water. Oh, saline. Sorry. Now, if you see, the mix is nice and compacted. It's a bit like how back in the day we used to do amalgam fillings. It's a bit like that. You mix it together like amalgam and push it in.
All right, question number 12 you have touched on, but we'll read it out. Is ethos suitable for post-extraction socket preservation where primary closure is not possible?
Yes, it is. It is suitable. Any material is suitable for it, or slash not suitable for it. With ethos, you have a bit of a safety net, primarily because if you, let's say in a site which you've done immediate extraction, you cannot, and you don't want to raise a flap and you want to allow for the secondary intention healing. In those cases, and if you're going back in 8 weeks' time, I would actually recommend not to place any socket grafting there. You would do socket grafting, or rather, I would do socket grafting, and I think literature supports it, is more important for patients who are undecided about implants. If you are going to say, okay, I don't know whether I need this tooth to be replaced, and patient wants to think about it 6, 8 months, a year later, that's when socket grafting actually comes, or rather becomes critical to maintain the ridge volume as such. But in a standard socket where you have no defects at all and the root is taken out intact with buccal plate, labial plate, and all the walls intact, you don't really need to put anything in there to grow bone unless you're leaving it for six plus months. Because when you go back into that site, no matter what bone graft you've placed, you will have to curate that area to reach host bone so that you can then actually place your implant not in graft but in actual host bone. So and I feel sometimes in grafted sites where the turnover has not been complete, it's very difficult to assess while you're doing the implant whether you've reached the host bone or not. So I would not recommend. I mean, I don't personally do socket grafting for all cases.
Question 14, do we need to make small perforations in the cortical bone before placing in EthOss?
I don't think it's a bad idea. You will get the bone cells, the blood vessels from the bone coming in. So I wouldn't say it's a bad idea. I don't routinely do it because a lot of times, let's go back to this case where there was exposure. Yeah. So here we don't have any, should I do the full screen? So on this, if you see, we don't have any buccal bone at all. So yes, I suppose you could have made some perforations, but if we go to the slide before this, I have used the degranulation burrs, and they cleaned out the site really, really well. So some amount of decortication would have probably happened with these decortication burrs itself. So once that is done and your site is nice and clean, if you want to do additional perforations, yeah, I don't think there's anything in the rule book to say no, because you are getting the blood vessels from the bone. So, but I suppose if it bleeds a lot, then you might have a little issue with setting of the ethos. But I mean, bone doesn't bleed that much. If it's a tiny perforation, it should still be fine.
All right, and our final question is, what is the indication and non-indication for you when using EthOss?
I would say, well, we talked about indications. The whole webinar was about indications of EthOss. But let's talk about a non-indication for EthOss. A non-indication for EthOss is any indication or any non-indication, or contraindication is the word we're looking for, would be an infected site. So if you haven't degranulated the site completely, or you're not sure of whether the whole lesion has been taken out, and you can't really see good host bone at the base of your site, then I wouldn't graft. So that I would call that as a contraindication. But everything else, wherever you need to graft, is an indication. Even with sinus lifts and stuff, you can, wherever you're using xenografts or you've traditionally been using xenografts, you can use EthOss. There are really no contraindications.
Thing we haven't touched on is that EthOss is bacteriostatic.
Yes.
So if it is open, when we were talking about all the socket preservations with not being able to get primary closure, it is bacteriostatic, so you won't have a fully infected graft if it is open to the oral cavity.
True. Well, of course, I'm aware of it, but I didn't want to harp on it because then there is this thing of, oh, you said it's bacteriostatic and I still got infection. So it's not an antibacterial. It's not amoxicillin in a way. So it is bacteriostatic. It is more resistant to getting an infection, but I would still say use solid surgical techniques and rely on the material as less as possible, really, for closures and things like that.
Yeah, so really giving predictable results following
The
the
bacteriostatic part of EthOss, I'll just mention one more thing, is I actually see it playing in my hands, is say, when you have an implant which is integrated, let's say I did I have one case going right now and it will be ready in a while. But let's say you have an implant which is exposed. Sorry, you did an immediate implant and there's a bit of graft failure, a little bit of inflammatory tissue ingress in it, and you need to curate that site. But the implant's integrated, so you don't really want to remove the whole implant. In those cases where your implant surface, in theory, has actually been contaminated by bacteria. So if you're a purist, you would say, okay, that implant surface is contaminated. I should remove that implant, chuck it, put another implant, and go ahead. That will, of course, be not be an easy procedure to do, and also it won't be very popular with your patients. So the bacteriostatic part of EthOss comes in very handy over there, because even after you curate out that inflammatory lesion or whatever, if there is slight amount of bacterial contamination, we still see graft uptake really well.
Excellent. All right, and that brings us to the conclusion of our question and answer sessions. And thank you very much, Dr. Kulkarni, for all your time this evening.
Thank you very much, and I want to thank everyone again to be so attentive with the webinar and actually asking some beautiful, meaningful questions. And we've actually had a great great time. I wish it was a bit more interactive. I suppose in the webinar you can't do it, but we could actually, if we were there in person, we could actually have these questions and brainstorm a lot more. So in the limited scope of the questions and the premise of doing a webinar, I hope I've given you as much information as I could, and feel free to reach out whenever or if ever you want to.
Excellent. Thank you so much. I'll speak
Thank
to you
you.
soon.
Thank you.